Hello, everyone. I'm Brian Hong from Taipei City Hospital, and this is
I'm Linda Chan from Taipei City Hospital as well.
today we have our great guest. It's from Massachusetts General Hospital in U.S. Dr. Conley, Jared Conley, and he brought us a new concept. I mean, at least in Taiwan, hospital at home. And can you, Jerry, can you tell us what is kind of a dream, but you realize it, you make it true, make it happen now in U.S. for about 10 years?
Yeah, absolutely. Such a pleasure to be with you all in Taiwan here. We're here, we've been talking a lot about hospital at home as the future of how we deliver much of acute care. Ultimately, what we've found is that patients want to maximize their time healing at home. And so what we've learned through the latest science and technology is that we can hospitalize a certain group of them that are low enough risk but still need hospital level care. So daily evaluation by a clinician, daily IV antibiotics or IV medications, and then often daily diagnostics, whether those be blood diagnostics or an x-ray, and that we can deliver all of that same care that they would get in the hospital in the comfort and convenience of their homes. And ultimately what we've found as we've studied that is that the outcomes are equivalent or better than hospitalizing them in a facility like a hospital. And so we have done a lot of work to advance this. We've infused a lot of different technologies to allow us to deliver this care for more and more patient populations. So initially a lot of work was done with patients with respiratory conditions and all sorts of different infections of the kidney, infections of the skin. Again, appropriately risk stratified by an experienced physician as well as appropriate diagnostics. And then those patients would get that same care that they'd get in the hospital, again, in their comfortable home, surrounded by their family, their pet perhaps. And we found people really enjoy it. If they've had that experience before, they often don't ever want to be hospitalized again in the brick and mortar facility. As long as it's safe, they'd rather experience that care in their homes.
Because in the past, the hospital, it's like the doctor's perspective. We want patient to be there, and we think it's safer for them. And now it's like a patient's perspective because patients don't want to be admitted. They want to be there with their pets at home. But some people will feel hesitant to embrace this concept because they think that patient might be in danger if they are far away from the hospital. They cannot get the emergency help immediately.
Sure. Yeah, it's certainly not for everyone. Everyone in our model has to consent to it. So we don't force anyone to do hospital at home if they don't feel comfortable with it. And sometimes it might not be the patient, it might be their family member doesn't feel comfortable to it. So we always ask for their consent. I would say again, as people become more familiar to it, they often want it more and more. But there is a percentage of folks that don't want this yet. There are a variety of reasons why that is. We've studied some of those reasons as a community. But ultimately, this isn't about forcing anyone into something they don't want. But it is much more patient-centric to at least give them the option, right? To be able to heal at home in a way that often allows for better sleep, better collegiality with your family members. We often joke that when was the last time you paid for the most expensive hotel in town but didn't get to choose your roommate, right? And that's sometimes how you could view hospitalization, right? If you're not in a single room occupancy, you often are there with a patient you didn't choose. And so most people choose to be hospitalized at home if it's deemed safe by their physician. But for those that don't, we can certainly admit them to the hospital.
Okay. because in July 1st, the government of our country, they want us to do that. But still people have concern about because it sounds not that efficient compared to the centralized hospital, and who pay for this? Because now the government they have project, but we fear that after this project, maybe it cannot sustain this system, hospital at home.
Sure. I think great points. Ultimately, there is some value of centralizing to produce more efficiencies. The reality, what we've found when we've studied this is there is a lot of fixed costs that are part of a brick and mortar hospital facility. To build a new hospital in the United States, it's often $2 to $5 million per hospital bed. Mm-hmm. So you could imagine some hospitals, depending on your size, could be $1 to $2 billion, right? There's a lot of fixed costs, and that's just to build it. Yeah. That doesn't talk about the electricity costs and other utilities. And so ultimately, sometimes you could see that there would be less efficiencies in not having all the patients together and having to go to various homes. But there's actually a lot of inefficiency of using a very expensive fixed cost if it's not needed, right? And so there's a balance there. And what we've found as we've studied this is costs are generally significantly lower in hospital level care. But ultimately, this isn't about doing something because it's cheaper. It's about doing something because patients heal better, right? They actually prefer it. Again, most patients highly prefer this care. They often heal at least as good, if not better. And what we're doing is, obviously, some of the initial measurements looked at mortality and readmissions, kind of hard outcomes that we study a lot. And they were found to be in randomized control trials either the same or better for hospital at home. But what we're thinking on is that we need to expand those metrics and really study the totality of healing that occurs and see just what are the other potential benefits that we might find. Certainly better sleep is theoretically a very keen metric that probably improves, and many others. What we have found is that oftentimes readmissions are lower for hospital level care at home compared to inpatient. Whether that's 7-day or 30-day readmissions. And then also that the use of rehab after hospitalization is often lower. You could imagine for us at our age, laying in a bed for 5 to 7 days is very deconditioning. Now, imagine being 80 years old and laying in a bed. There's not a lot of movement in a hospital. But in hospital at home as a care model, there is much more mobility. Yes. And much less deconditioning. And so what we do see is lower need for nursing home admissions in this model, which again, there's, I think, lots and lots of benefits.
But it requires lots of faculties. I mean, you need more members to achieve like the home care, because the remote, the transportation, and even each time you can just see limited patients. So how do you solve the problem?
Yeah, I think when people first start to think about and build a hospital at home unit, they're a little overwhelmed because there are a lot of costs to build this. Yeah. And if you just look at some of those costs compared to delivering things in the hospital, you can often be confused because it seems to be more expensive. But again, it's often because you're not thinking about all the fixed costs and all the efforts it takes to run and build a hospital, right? So we often talk about, you need to think about yourself as needing many of the same resources as it takes to build a hospital, right? Both capital as well as staff, right? Yes. There's all sorts of capital costs and there's all sorts of staffing costs to build a hospital. And you need to kind of compare apples to apples, right? So there is a lot of upfront costs, especially to try and build a program. And there's a lot of continued cost with staffing, with vehicles, right, or paying for parking or all these things. But the good news is the centralized societal resource we call hospitals, they are very expensive. And so there is actually a lot of opportunity to rethink how we use that money in a way that ultimately provides better healing.
Now I kind of embrace this concept because, when we admit the patient in the hospital, we always, when we want to discharge him, we always need to find a way for him to be home. Because for some patient, when they was admission, the function is getting deteriorated, and sometimes it's hard for them to go back to their home. So we need to make efforts to make them back home. So it's like that. If they are just at their home, there's no need for this gap.
Yes.
Yeah. Okay. So I kind of I agree with you now, and but can you describe how you manage the system for the hospital at home in MGH? Because in Taiwan, I think most of the hospital we don't have this kind of experience. And
Sure.
Can you give us some vision about it?
Yeah, absolutely. To most physicians and nurses and administrators, this model is very novel at the beginning, right?
Yes.
And so when we were first starting out, there was a lot of unknowns, right? And so we can relate to your experience. Again, we've only been at this almost to a decade now. And ultimately, it took a lot of careful, thoughtful planning and building from a small hospital at home unit that I was often just taking care of, 2 to 5 patients a day, very small, and starting with some very narrow patient populations that we felt safe to start with. And then we've slowly, over the last several years, built that and developed more confidence in knowing, again, how many physicians we need, how many nurses we need, what type of patient populations are best for this program, what are the inclusion and exclusion criteria. And sometimes you have a case that doesn't go as expected and you have to put a new inclusion or exclusion criteria in, right? And so we're continuously learning, as any health system should be. But ultimately, we now are averaging about 40 to 50 patients each day. So our average daily census is quite high. That's across 2 academic medical centers and 3 community hospitals. So each providing patients that are amenable to get this type of care. And we're ultimately trying to build up towards taking care of up to 10% of our inpatient volume in the comfort and convenience of their homes. So it's a journey where many of us are on this together. There's over 300 hospitals in the U.S. that are in various stages of planning or actively doing hospital at home. And right now in our government, there is a bill put forth to extend this work for another 5 years, and we hope ultimately permanently. And I think when that becomes the case, and it looks more and more that this will be a permanent payment model, you will actually see a very advanced effort across our nation in the United States to do as much healing for acute illnesses in the home as is safe and is desired by patients.
But how many crew members do you need in each visiting? I mean, a group of people, how many staffs you need? For example, how many physicians, how many nurses you need in a group?
Yeah, it depends a lot on your geography and what type of patient populations you're taking care of and what your average daily census is. Ultimately, it's actually not much different from what you do in a hospital, right? And so you can think about it as very similar in terms of your ratios. There's obviously a little bit of difference because of the geographic travel that needs to happen. But what we found is we like to maximize the use of our virtual technologies or our video visits so that the physician or the physician assistant or the nurse practitioner can make a decision on whether it's appropriate to visit them virtually or to go in person. And so there are some advantages of being thoughtful about, again, using the latest science and technology and the clinician's experience to know when is it safe to be in person and when is it safe to be virtual. There's always generally, again, at least one visit. If it's a Medicare patient, then 2 visits every single day by a nurse or a paramedic, because there's often IV medications that need to be given or blood diagnostics that need to be obtained. And so there's always generally at least one human in the home every day, often 2. but it's really just thinking carefully and trying to match similar to what you do in the inpatient side with some nuances.
I think except for the patient's need, because we can see that because the Asian people, they are getting lots and it's a silver tsunami, and all the medical systems are facing the same way. So in your point, how will the hospital at home to solve this or assist it?
Yeah, ultimately, I think this is one of the key solutions to help us address the silver tsunami. What we find is that, in the U.S. and many nations, the population over age 65 is going to often double or near double in the next couple decades. And I don't know if it's like you, but in my city, to build a new hospital to help care for these increasing aging populations can often take a decade, right, in terms of planning, building, and finishing. And we often don't have a time we don't have 10 years, right? As emergency physicians, we often feel the capacity challenges and with ED boarding. And so ultimately it's much faster although it takes a lot of effort and careful planning to build a hospital at home unit, you can do that pretty well within a year, as opposed to the upwards of several years that it takes to build a new hospital. So what we see is there will still need to be new hospitals built to help address this silver tsunami. But what we hope for is building less of those than otherwise would be needed by choosing the right patients that can safely get hospital level care in the comfort and convenience of their homes.
Okay, so what kind of patients so far the most patient who need a hospital at home, what kind of disease you have already make your approach for these patients?
Sure. Actually, a variety of diseases. I'd say the core diseases are respiratory in nature and infections in nature. So think about COPD, pneumonia, kidney infection or complicated UTI, and heart failure as another one. Kind of those are the core diagnoses that we see the most prevalence of condition for hospital at home. But there's a host of others. You can think about people that go to spin classes and haven't worked out in a while that get rhabdomyolysis. They're often, as long as they're not going into kidney failure and needing dialysis, those patients are actually very great for hospital at home. We're looking at a lot of post-surgical patients. So they still get their surgery in the OR. They still spend some time in the PACU, and maybe they even need 24 hours or 48 hours in the hospital, but they can then be transferred to their home much earlier than they otherwise would be. And we see this gaining more and more traction. We're treading carefully because there's not as much evidence in the post-surgical space, so we're choosing carefully who we choose to do this on and making sure that we're doing it safely. But there's a lot of great cases. More recently, there's been a lot of work to try and expand this to neurologic conditions that are needing hospitalization, to oncology conditions. A lot of interest in the area of febrile neutropenia, as you could imagine. And then in OB, actually, also, maybe after delivery, getting the patient home with, again, appropriate monitoring of physiology, if it's needed, or just appropriate clinician evaluation at the cadence that's needed.
Okay, so yesterday you mentioned another concept. I think it's quite brand new, at least for me, the ED at home.
Yeah. ED at home, my colleagues just published in the New England Journal Catalyst just yesterday. Some of my friends in Boston around their model. My group at my colleagues at Mass General and I, and several others around the country have started to build out what I'd often refer to as kind of a lower tier version of hospital at home, or a version that you could also say is ED at home. So there's kind of ED at home, there's observation at home, which would be kind of hospital at home light, and then there's hospital at home. right? For ED at home or ED in home, what you're seeing is patients that have often elderly and can't get to the emergency department easily, require an ambulance to get there often, that you can have a paramedic go to the home. You can have the emergency physician be virtually visiting by video synchronously, along with our whole team of staff, right? A nurse, a triage nurse, and nursing oversight, and coordinators, and the whole what might be needed to make a diagnostic evaluation of a patient. Sometimes, if they have redness in their leg, you might not need to do blood work. But say they have generalized weakness and they're 80 years old. You might want to check their kidney function, their electrolytes. You might want to see if they have new anemia. And so that blood work can be done by the paramedic, directed by the emergency physician. And you can get vitals. And so much like an emergency department visit, but again, in the comfort and convenience of home. And what we found, of course, is this is an expensive model, but as long as you are getting adequate volume to see enough patients every single day, it can actually be cheaper than them coming to the emergency department. And that's what that study showed yesterday that came out. It was about $1,250 cheaper per encounter. Again, as long as you're seeing enough patients per day. And so that's a really exciting model. I think a lot more work needs to be done there. We're thinking carefully about, again, who are the right patient populations to apply this model for. And there's still a lot of work in that middle ground of observation at home where they don't necessarily, at least in the US, meet the criteria for staying in the hospital for 2 midnights. But they also don't make, they're also not safe to be discharged, right? And so there's a lot of efforts to think through how do we safely and effectively care for that population, who often is a great candidate for home-based care as well.
And what are the diagnostic tools you used for this point of care diagnosis? For example, like sonogram or even lab, there's any kind of point of care lab that you use for this home care?
Yeah, so we use a couple different types of point of care diagnostics that the paramedic will get some blood work, and we can get creatinine, we can get electrolytes, we can get hemoglobin and hematocrit. And there's actually, we're talking about the opportunity to even build that diagnostic engine out more at a conference here next month in Chicago, the ADLM conference, which is the largest conference for diagnostic and laboratory medicine, certainly in the U.S., maybe beyond. And so they've asked us to come and speak on the topic of hospital at home and ED in home, and how do you effectively build out those diagnostics in a way that allows us to take care of more and more patients at home. In terms of ultrasound, we've done, as a community, a lot of work in that space to be thoughtful about not having to bring them back to the hospital, but being able to do point of care ultrasound. And some of that needs to be, training of our paramedics and our nurses. There's exciting opportunities with AI to help both train and capture and read those images. So there's some studies, right, that show that will teach someone who's already had a little training how to move the probe marker to obtain the right image. And then we'll tell them the next image that needs to be obtained, and then ultimately provide information for a limited TTE that's been found to be excellent resource when, again, it's the appropriate use case. Some patients need a more comprehensive echo, but again, if it's a quick evaluation for an evaluation of shortness of breath or something else, you can quickly rule out pericardial effusion or significantly reduced ejection fraction.
Great.
So what kind of cases that you face may have to be readmitted?
Yeah. We often refer to it as an escalation of care. And so the escalation rate in most programs around, at least in the US and often beyond, from what I've seen in my travels, is about 5 to 10%, usually around 7%-ish is the average. And the escalations are often for things that aren't again, lights and sirens and patient decompensating to the point of near death, it's generally almost never that. In fact, the mortality rate is well less than 1%, often around 0.3%. And so it's generally more for patients that, for instance, they're a heart failure patient and their creatinine is slowly going up while they're getting IV diuresis. And so they, unfortunately, have meet a risk profile that now would need to be in the hospital, or their electrolytes as you diurese them are going too low, like their potassium, right? Had a case of that recently, where the potassium was 2.1 and it was felt to be unsafe to keep them at home, and so they had to be escalated back to the hospital. But those are the type of examples. It's almost never that a patient needs immediate, urgent, life-saving care and is rushed back to the hospital in that manner. It's almost never.
Okay.
We as a house of medicine are very conservative, and so we choose very carefully who can go home and who can not. And I think that's a nice safety mechanism which has kept us from not having almost any patients die or near die at home when it's not in their goals of care. There is times where sometimes they might be in hospital at home, and during the case of that, they express interest in transitioning to hospice, and they might die naturally then over the next few weeks. So that's another opportunity that exists, as it does in the hospital setting. But from an actual acute illness, it is almost never the case that they would pass away in hospital at home.
Okay, it's such a pleasure that I think I see the future ED at home, hospital at home, because we are facing some aging people's problem, and it's quite probably that we will need this kind of system when we're getting old. So it's very mind-blowing for your speech and this concept about the hospital at home. And once again, thank you. I heard that it's the first time you come to Taiwan, right?
Yeah, I love the beef noodle. It's very good.
The beef noodle.
Yeah, I've really enjoyed my stay here. It's been wonderful to be with everyone.
Great.
And look forward to continuing to share best practices.
Okay, thank you.
Thank you.
Thank you so much. We wave to the camera.